Good afternoon. I'm Alexandra Wixon, and I work in the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of CDC's One Health office, I'm pleased to welcome you to the monthly Zoonoses and One Health updates call on October 4th, 2023. We are aware of the emergency alert going out to cell phones at 2:20 p.m. Eastern Time today, and we plan to move forward with the presentations. However, if it interferes with our presenters' audio, they may take a minute to go on mute until the alert is complete. Next slide. Although the content of this webinar is directed to veterinarians, physicians, epidemiologists, and related public health professionals in federal, state, and local positions, the CDC has no control over who participates. Therefore, please exercise discretion on sensitive content and material, as confidentiality cannot be guaranteed. Today's webinar is being recorded. If you have any objections, you may disconnect now. Links to resources from each presentation are available on our website at cdc.gov/onehealth/2023/october.html. Next slide. Today's presentations will address one or more of the following 5 objectives: identify an implication for human, animal, and environmental health, identify a One Health approach strategy for prevention of public health threats, identify a One Health approach strategy for detection of public health threats, identify a One Health approach strategy for responding to public health threats, and list 2 ways to improve collaborative practice across the public health care team. Next slide. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC, our planners, presenters, and their spouses/partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. The Planning Committee reviewed content to ensure there is no bias. Content will not include any discussion of the unlabeled use of a product or product under investigational use, with the exception of Dr. Samantha Gibbs' discussion of the emergency use of conditionally licensed vaccine in California condors. Dr. Gibbs will be discussing vaccinating California condors to protect against highly pathogenic avian influenza. CDC did not accept commercial support for this activity. Next slide. Instructions for receiving free continuing education are available at cdc.gov/onehealth/ZOHU/continuing education. The course access code is ZOHU Webcast. To receive free CE for today's webcast, complete the evaluation online by November 6th, 2023. A captioned video of today's webinar will be posted on our October ZOHU call page within 30 days. To receive free CE for the web on-demand video of today's webinar, complete the evaluation online by November 7th, 2025. Next slide. Before we begin today's presentations, Colin Basler, Deputy Director of the One Health Office, will share some news and updates.
Thanks, Alexandra. Good afternoon, everyone. Thanks for joining us for the October ZOHU call. We invite you to share the ZOHU call website link with your colleagues from the public health, agriculture, wildlife, plant, environment, and others, so we can let them know about the live webinars, video recordings, and free continuing education that the ZOHU call offers. Before our presentations start, I'll take a moment to share some updates and resources. As always, you can find links to these resources in today's ZOHU call email newsletter. And of course, if you aren't yet subscribed to the newsletter, please sign up using the link at the top of the main ZOHU call webpage so you can get this monthly update from us. In today's newsletter, we highlight several recent publications, including the cost and benefits of primary prevention of zoonotic pandemics, predicting food sources for Listeria monocytogenes based on genomic profiling using random forest model, and SARS-CoV-2 surface contamination in Metro Atlanta grocery stores. Next slide, please. Additional publication highlights include a couple of notes from the field on gastrointestinal illnesses among hikers in the Pacific Crest Trail in Washington, and an outbreak of norovirus illnesses caused by consumption of oysters harvested from Galveston Bay, Texas, and a publication on reported global avian influenza detection among humans and animals during 2013 to 2022. Next slide, please. You can also find web resources and announcements in the newsletter, including links to a couple of CDC health updates regarding locally acquired malaria cases identified in Florida, Texas, and Maryland, and another update on severe Vibrio vulnificus infections in the United States associated with warming coastal waters. Next slide. Additional resource highlights include new CDC COOPS videos. Episode 1 is titled Doja Chicks, and episode 2 is Chick In. That's Chick INN if you're audio only. If you ask me, it's a few minutes well spent. Next slide, please. Finally, for announcements and web resources, we've linked the Federal Register notice for public comment on the draft National One Health Framework to address zoonotic diseases and advance public health preparedness in the United States, a framework for One Health coordination and collaboration across federal agencies. And on a related note, in the events and observances section, you'll find links to register for the informational Zoom webinars about the Federal Register notice for public comments. Next slide, please. October events and observances that may be of interest include Global Hand Washing Day, which is October 15th, and then Bat Week on the 24th through 31st of October. And finally, the 2 informational webinars will take place on October 12th and October 18th. Next slide, please. We've also shared several updates on several ongoing outbreak investigations, including a salmonella outbreaks linked to small turtles and backyard poultry, and a listeria outbreak linked to ice cream, and update on a fungal meningitis outbreak associated with procedures performed under epidural anesthesia in Mexico. Next slide, please. You can visit CDC's Healthy Pets, Healthy People website for a selected list of ongoing and past U.S. outbreaks of zoonotic diseases, and find details about ongoing U.S. outbreaks on the CDC websites linked from today's newsletter. Our next ZOHU call will take place on November 1st, 2023. Please continue to send presenter and topic suggestions for future presentations, as well as news from your organization, to zohucall@cdc.gov. That's zohucall@cdc.gov. And with that, I'll turn the call back over to Alexandra. Thanks.
Thank you. You may submit questions at any time using Zoom's Q&A feature. Please include the topic or presenter's name. The Q&A session will follow the final presentation as time permits. You may also email questions to today's presenters. We've included their email addresses on this slide, on the ZOHU Call webpage, and in today's email newsletter. Next slide. Today's first presentation, Vaccinating California Condors to Protect Against Highly Pathogenic Avian Influenza, is by Dr. Samantha Gibbs. Please begin when you're ready.
Hi, thank you for having me today. I appreciate being given the opportunity to present. Today, I'll tell you about our efforts to vaccinate California condors to protect against highly pathogenic avian influenza. Next slide, please. So in March of 2023, we began seeing the start of a mortality event in California condors in Arizona. By April 12th, we were up to 21 dead condors. 19 of those we were able to confirm as being caused by Eurasian lineage goose guangdong H5 clade 2344B. The other birds that we were unable to confirm, we were unable to recover those carcasses from the landscape. That's up in northern Arizona. It's a very wild location, and there are many issues associated with recovery of carcasses as a result of the need to climb down into canyons and things like that. So we were lucky to be able to recover the 19. The other birds, we knew where they were based on their satellite telemetry devices. We just weren't able to get to them. 2 of the birds that were confirmed with H5N1 were actually sent down to a rehabilitation center in Phoenix, Arizona. Those did survive with intensive supportive veterinary care, and they have been re-released into the free-ranging population of condors. So at the very beginning, with the first couple condor deaths, we set up an emergency response incident command within U.S. Fish and Wildlife Service, and also including several of our partners that work on the California Condor Recovery Program. We also began thinking of all possible solutions to limit the impact of highly pathogenic avian influenza on the population. And these included making improvements to our operations, our day-to-day operations, through increased biosecurity. We wanted to better address any other stressors that might be creating immunosuppression in the condor flock. And then we also threw out the idea of whether we might be able to vaccinate birds. Next slide, please. So I'll give you a little bit of the history of condor conservation, and this led us to our decision to even try vaccination. So in 1967, the California condor was listed under the Endangered Species Preservation Act. A recovery team was established, and then the last wild condor was captured. There were so few condors at that point that we felt that bringing them in to captivity was going to be necessary in order to save the population. Breeding began the following year, and then the first captive reared condor was released back into the wild in 1992. From there, we began establishing release sites in California and Arizona. And those were an effort to move birds as they were being produced in captivity to the landscape to form flocks that are free ranging. Next slide, please. So this gives you an idea of where those flocks are now. There are 5 condor release sites, and those support flocks in Arizona, California, Mexico, and one in the Pacific Northwest. These feed into the free-ranging flocks, and the captive breeding facilities are located in Idaho, Oregon, California, and also Mexico. Next slide, please. So the California condor population in 2022, which is the last year for which we have complete information since we're still in 2023, the total world population is 561 individuals. Of that, 347 are in the free-flying population. And in the Arizona-Utah flock, there's 116 birds, and that's the flock that was being impacted by highly pathogenic avian influenza beginning in March. The total captive population is 214. So in 2022, we had a total of 20 deaths within that free-flying population of 347. And then you compare this to the 21 birds that we lost in a month to highly pathogenic avian influenza in just one flock. That's 116 individuals. And you'll probably understand why we were so concerned about this disease event, because it was such a severe impact to that local population. But we also need to keep things in perspective with other stressors on these birds. At the moment, lead poisoning is considered the biggest problem impacting California condors at the moment. For 2022, 49.8% of the, So over the past several decades, 49.8% of the 253 deaths that we've seen with a known cause were as a result of lead poisoning. Next slide, please. So I want to stress that vaccination is really just one part of a comprehensive approach to ensuring the survival of California condors across their range. And we really wanted to consider all possible solutions to limit the impact that highly pathogenic avian influenza might have on the population. So we wanted to ensure that we were educating our stakeholders, the agencies, nonprofits, and zoos that we work with in the Condor Recovery Program. Make sure they understand the avian influenza epidemiology so that our efforts in biosafety and biosecurity are understood and applied appropriately. We also put effort into improving our operations by limiting the number of birds that are being caught in traps at the same time, stopping food and water provisioning so that we're not congregating birds falsely, setting up facilities for veterinary care, such as the rehabilitation center that provided immediate care during the mortalities we saw at the beginning there. And then constructing pens for holding birds while testing for highly pathogenic avian influenza prior to transporting those birds. In some cases, zoos where we would usually send sick birds from the wild are no longer able to accept birds if they are positive for highly pathogenic avian influenza. We also wanted to increase biosecurity and biosafety. We conducted flow analyses through the facilities to see if improvements could be made there. We retrofitted traps and flight pens with solid cover to prevent fecal contamination by wild birds, as well as changing flooring from a gravel dirt surface to a solid surface so that it could be disinfected. Those are examples of just a few of the biosafety and biosecurity improvements that we've made so far. I mentioned the other stressors of lead. Capturing birds is also a stressor. And so we wanted to be very careful that we were only capturing, moving, or containing birds in captivity if it was absolutely necessary. Sorry about that. So lastly, our request to USDA for vaccination was in part because all of these other possible solutions would not be complete, and we have such a small number of birds on the landscape. We felt that it would be appropriate to pursue that possibility. Next slide, please. So in order to provide vaccination, though there were many hoops to jump through, the first was needing approval by the USDA as well as the individual states' departments of agriculture to use the vaccine. So we worked with USDA to see whether it might even be a possibility, specifically for threatened and endangered species. They did grant us a special use for the vaccine. And we began reaching out to the states to see whether or not they would be willing to allow us to apply that vaccine within their states. So the USDA helped us through that process as well. We also needed access to a vaccine that would work against the currently circulating strain of highly pathogenic avian influenza in North America, the 2344B strain. And also we had a requirement from USDA that veterinarians would be needed to administer the vaccine, whereas in some cases we are able to distribute other vaccines to wildlife species, free-ranging wildlife species, through our biologists who are doing the capturing. So this was another logistical challenge that we needed to overcome. We also needed to make sure that we had all the correct permits, both state and federal, as well as handling endangered species. moving birds over state lines, as well as being able to do research. We wanted to cover our bases as well in terms of animal welfare and to submit our proposals for any research trials to an animal care and use committee for their review. Next slide, please. So once we were granted the emergency use authorization by USDA, we really needed to think further about how we might apply that. Highly pathogenic avian influenza vaccination has not been done on a routine basis before in the United States. And so this was really a first, not just for us, but for USDA as well. And so with that emergency use authorization on April 2nd, we had requested threatened, endangered, or species of conservation concern. USDA did agree that the status of the California condor did warrant extraordinary action. However, they asked that we limit that emergency use authorization just to California condors, as well as a few captive wild vultures that we wanted to use in a safety evaluation. So at this point, we are limited to vaccination of California condors, but it may be that in the future we could expand that to other species of threatened or endangered birds if necessary. Next slide, please. So the vaccine we elected to use was donated to us by Zoetis, and it is a killed vaccine, which USDA was most comfortable with in comparison to some of the other vaccines that are also in development. The Zoetis vaccine was also already conditionally licensed by USDA for stockpile purposes during the 2014-2015 highly pathogenic avian influenza outbreak in the US. This is a water and oil emulsion vaccine, and it's an antigenic fraction, which is comprised of a recombinant virus constructed via reverse genetics, which is all a bit of a mouthful. Basically, it includes the internal genes for the H1N1 vaccine strain, and then the hemagglutination H5 gene from a gyrfalcon virus isolate that was isolated during that 2014-2015 outbreak. Next slide, please. So before immediately using the vaccine in condors, we wanted to do a trial in a surrogate species first, just to determine safety and perhaps look and see whether their antibody response was significant enough to warrant moving into doing a trial in condors. So we used black vultures. 10 of those birds were vaccinated with a 0.5 ml dose, which is the standard dose for poultry. And that was given in 2 doses with 21 days in between, so a prime boost. And that's how the vaccine was designed to be used. We also vaccinated 10 birds with a 1 ml dose, which is double the standard dose, and did not provide a booster. The reason for that was to see whether or not we would be able to use that approach for birds in the wild, rather than having to either recapture them after 21 days or to hold them for 21 days or more. 5 birds were then held back as a control group, and those did not receive any vaccine. We collected blood samples every 10 days for ELISA screening and hemagglutination inhibition testing, both for looking at antibody titers against highly pathogenic avian influenza. Unfortunately, we're not able to conduct a virus challenge study for the efficacy, which is something that would be conducted in poultry. For obvious reasons, we did not want to challenge condors with a highly pathogenic avian influenza. virus. Also, we don't have very many facilities that could handle having black vultures in them either for experimental trials. So at this point, we are using the antibody response measurements as a proxy for looking at challenge studies to live virus. Next slide, please. So for the 27 of the 28 black vultures, we tested them all before we started the trial. One of them had been exposed to a low-path avian influenza prior to the study. We did the prime boost and looked at those guys. 90% of those birds showed titers on the hemagglutination inhibition that would be expected to provide protection against mortality and morbidity based on the trials that have been conducted in poultry. A single injection of 1 ml without the booster had a lower level of antigenic response. 70% of those birds showed titers expected to provide protection. Next slide, please. So for the California condors, once we had those results from the vultures, we did not see any safety issues, and we did see an immunogenic response. So we elected to move forward with a trial in California condors, which mirrored the same construct as the trial for the black vultures. Again, all vaccinated birds, this time condors, did just fine. 2 of the birds had a small amount of swelling and hemorrhage at the injection site following vaccination. But other than that, we did not see any safety concerns. As far as efficacy goes, for the prime boost, this time we only saw 60% of the birds showing titers that would be expected to provide some level of protection. Based on the trials in poultry. And again, we're having to extrapolate from information we have in poultry because we have not done this before in condors. For the single injection of 1 ml, we have not yet completed that testing. However, the preliminary results are suggesting that a very small number of birds are responding well to that 1 ml dose without a booster. Next slide, please. So moving forward, we will be seeking this week, actually, approval from the U.S. Fish and Wildlife Service Directorate to see whether or not we can use the vaccine on a more routine basis, given the results that we have in the trials. Once that's decided, if we do elect to move forward, the final vaccine protocol for routine vaccination in captive and wild California condors will then be based on the final results as well as the logistics of vaccinating captive and free-ranging populations. So there are really 3 compartments within the condor recovery program. One is birds that remain in captivity and serve as breeders and mentors. The second group are birds that have been hatched in captivity and will be sent to the release sites for acclimation and then release. And then the third compartment are free-ranging birds that are raising their own chicks in the wild. So you can imagine that there would be different logistics for routine vaccination of each one of those groups, as well as the fact that each one of those groups has a different level of risk in terms of exposure to highly pathogenic avian influenza. The question about whether to use the primer boost or 1 double dose, both the vulture and the condor results so far suggest that the double dose approach all at once without the booster isn't particularly effective. So it's most likely that if we do continue, we would be using that primer boost approach with 3 weeks in between for captive birds. The next question for us is going to be, how often will we need to vaccinate, i.e. how long will that protection last? And that's not a question we can answer right away. We'll need a little more time to see what happens with the antibody response. Because this is a killed vaccine, we are eliciting a humoral response, but not a mucosal or cellular response. So the amount of time that we see that antibody response may be less than what we might see with other vaccine platforms. The antibody studies will continue in our captive birds that were part of the safety trials. And then we will also be looking at birds that are free ranging in the Arizona flock to see whether they had developed any immunity, those that were not victims of highly pathogenic avian influenza outbreak in March and April, to see whether they did raise effective titers to protect them from disease. So we want to know what that exposure rate was in that wild flock and what we might expect to see on top of that if we were to apply vaccination. We're still working with USDA to see whether that requirement for application of the vaccine only by veterinarians, whether we can come up with a solution for that, because the sites where we are capturing and tagging condors can be very remote and capture can be quite difficult. It would be logistically challenging for us to have a veterinarian on site at all time in order to vaccinate a bird just in case we catch one. Next slide. So we still have some challenges ahead of us. There's the question of whether we should even be vaccinating wildlife for infectious diseases, or whether we should be allowing for population resistance to build naturally. Because the bench strength for this species is so slim, we decided that we would give it a try and see if we could at least protect them for some period of time, depending on how things work out epidemiologically with the highly pathogenic avian influenza activity that we're seeing in North America at the moment. In terms of allowing population resistance to build naturally, we'll wait to see what the natural exposure rate was of individuals within that Arizona flock. All birds that we capture will have a blood sample taken, and we will have a look for antibody response. I mentioned that we don't know how long the protection will last of the vaccine. It may be fairly short, and we may need to provide boosters either every 6 months or every 12 months. And then whether or not we can meet all of the criteria for both the USDA and the state agricultural agencies to use the vaccine at all of our locations. Some locations are AZA accredited, meaning they have passed a high bar of biosecurity and biosafety, and so USDA is quite comfortable with those facilities having vaccine on site and the trade implications for using the vaccine in the US. So they want to make sure that we are not doing anything to jeopardize the poultry trade. We've also got the logistics of routine vaccination, which I mentioned regarding the field sites. And so we'll have to work through those and balance that against the level of protection that we feel the vaccine might provide. Next slide, please. So I've been talking just about the California condors so far, but I thought I would mention that there are other birds that the U.S. Fish and Wildlife Service has on their threatened species list. We've got whooping cranes, Mississippi sandhill cranes, quail, and greater prairie chickens that we are equally concerned about. Something that's unique to the condor population, however, is how tightly managed that group is, and every single bird has a number on it and a transmitter of some sort, whether that's a radio transmitter or a satellite transmitter. So these other populations that I have listed there, those might be more problematic in terms of passing the level of scrutiny that would be required for USDA to grant an exception for the use of vaccine in those species. We're also seeing many wild mammalian cases of highly pathogenic avian influenza. And of course, we have several species we're very concerned about in Fish and Wildlife Service, being the black-footed ferret, ocelot, and the Florida panther. So first, we're going to work with the California condors and see how that all goes. And perhaps if we feel it necessary moving forward, we might explore on a case-by-case basis with USDA and the state agricultural agencies whether or not we might look into use of vaccine in those other species. Next slide, please. And that's it from me. My email address is there at the bottom if you would like to reach out with further questions. Thank you.
Thank you so much, Sam. Our final presentation today, Louse and Flea-Borne Diseases, Implications for People Experiencing Homelessness and Their Animals, is by Dr. Shannon Rich and Dr. Ann Carpenter. Please begin when you're ready.
Thank you. Hello, everyone. I'm Shannon, and I will be providing the introduction and overview of our study on these topics, and then I will pass it over to Anne for the companion animal section and conclusions. Next slide. On any given day in the United States, more than 500,000 people are experiencing homelessness. And while many of these people live in shelters, depicted in this image on the left, 2 out of 5 are unsheltered, depicted on the right, sleeping on the street, in tents, or sometimes in cars. Each of these living conditions can increase the spread and severity of infectious diseases within the population. As a result, pathogens spread by disease vectors like body lice and fleas disproportionately impact people experiencing homelessness. Next slide. Body lice are distinct from the more common head and pubic lice, and they are spread by close physical human contact or by sharing clothing or bedding. Body lice live on the clothing and bedding where they lay their eggs, also known as nits, and they reside close to the skin to maintain their body temperature. These are ectoparasites, and they feed on human blood, which they do often several times a day, moving from the clothing to the skin for a blood meal. Body lice are competent vectors of Bartonella quintana, Rickettsia prowazekii, which causes epidemic typhus, and Borrelia recurrentis, which causes louse-borne relapsing fever. Next slide. In summer 2020, in the midst of another surge in COVID-19 cases, many homeless shelters were closed or operating at reduced capacity as staff were told to stay home to limit the risk of COVID-19 transmission. For those who were living on the street, access to regular hygienic services became increasingly difficult. A cluster of unusual infections were reported in the Denver metropolitan region, a disease caused by infection with Bartonella quintana, sometimes referred to as trench fever. The origin of the moniker trench fever is because it once afflicted millions of World War I soldiers who were forced to spend months living in squalid conditions during trench warfare, often becoming infested with body lice. Next slide. The clinical presentation of Bartonella quintana infection includes an acute disease that is marked by recurring episodes of fever. The name Quinton originates from the observation that these febrile episodes seem to occur every 5 days. The line graph on the right shows recurrent episodes of fever in someone diagnosed with acute infection. Please advance. However, subacute disease is more commonly recognized and diagnosed than acute disease and is typically seen in patients as fever of unknown origin or prolonged asymptomatic bacteremia, which can last months to years. Endocarditis is the most common manifestation, which can infect the heart valves and cause valvular dysfunction, heart failure, and multi-organ failure. This image on the bottom right is from an echocardiogram illustrating large vegetations or visible clusters of bacteria on the mitral valve. Next slide. In addition to body lice, rodent and cat fleas found on rats, cats, dogs, and possums can also spread diseases. fleas do not live on human hosts, but they can transmit diseases to humans when they jump onto us after being infected by an animal host. Transmission occurs to humans when infected flea fecal matter, also known as flea dirt, enters breaks in the skin or wounds. Both rodent and cat fleas are competent vectors of Rickettsia typhi bacteria, which is the cause of flea-borne typhus, also referred to as murine typhus. And rodent fleas are also competent vectors of Yersinia pestis, the cause of plague, while cat fleas can transmit Bartonella henselae, the cause of cat scratch disease. Next slide. Flea-borne typhus used to be widespread in the United States. However, improved waste management, insecticides, rodenticides, and rat proofing reduced reservoir populations, leading to a marked decrease in cases. The disease was formally pulled from the nationally notifiable list in 1988. Next slide. Despite great success against flea-borne typhus following World War II, the last couple of decades has seen a resurgence in reports, particularly in places like Texas and California. This MMWR, which was published just a couple of months ago, reports on a rise in flea-borne typhus cases that occurred in Los Angeles County last year and was associated with 3 deaths. The last time flea-borne typhus was associated with a death in Los Angeles County was in 1993, 30 years prior. Next slide. The symptoms of Rickettsia typhi infection, or flea-borne typhus, include fever, headache, and rash, also known as the rickettsial triad. However, these symptoms can be variably present, with only 50% usually presenting with rash, which can be challenging for detection and diagnosis. Although rare, fatalities have been reported, and severe illness can occur in some individuals, leading to organ damage and hospitalization. Next slide. People experiencing homelessness face an elevated risk of flea and louse-borne diseases, yet there is a notable lack of understanding regarding these diseases among the staff providing services to this population. To address this gap, we undertook a study across 7 U.S. states with the central goal to identify gaps where knowledge, prevention, and intervention could be improved. Next slide. In particular, our goals were to assess staff knowledge, attitudes, and practices regarding body lice, fleas, and associated diseases, determine barriers to implementing body lice and flea prevention measures, and finally learn how workers would prefer to learn new information. Next slide. To accomplish these aims, we partnered with public health agencies in regions with large populations of people experiencing homelessness to identify shelters and outreach organizations for recruitment. Next slide. Quantitative and qualitative data were collected using a structured, standardized questionnaire administered by study staff, and we recruited between 2 and 5 staff per site for the survey, including case managers, outreach workers, and operations managers. Surveys were administered throughout counties in California, Colorado, Georgia, Maryland, Minnesota, New York, and Washington. Next slide. And within these states, we selected sites to visit together with our health department partners. The blue stars represent the counties we visited in each state for the study, and here are the counties visited in the first 4 states. Next slide. And the counties visited in the remaining 3 states. Next slide. In total, we recruited staff from 89 sites and surveyed 333 total participants. Next slide. Now I will go through some of the findings from this study. Next slide. We found that about 1/3 of shelters reported providing medical services on site, and nearly all shelters reported that clients had regular access to laundry services and showers. Next slide. This was in contrast to outreach settings where about half of the organizations reported providing medical services while access to laundry and showers was much more limited. Next slide. In terms of staff attitudes towards body lice and fleas, most felt that they are a problem for people experiencing homelessness, with 74% agreeing that body lice were a problem and 68% agreeing that fleas were a problem. Next slide. On average, participants correctly answered about 6 out of 9 body lice knowledge questions, and these composite scores did not differ significantly between shelter and outreach settings. Next slide. Looking at some of the individual components of the knowledge score now, we see that the majority of participants were able to correctly identify the image of body lice, which are shown in this picture of someone's sock. Next slide. Nearly all participants were aware that body lice can spread directly from person to person. Next slide. A smaller percentage were aware that body lice lay their eggs in seams of clothing. Next slide. About the same knew that washing clothes and bedding can kill body lice. Next slide. And that showering or bathing can prevent body lice. Next slide. When asked which diseases can be transmitted by body lice, the majority of participants responded, "I don't know." Among the diseases that were selected, Lyme disease and malaria were the most common. Both were incorrect answers. 16% correctly answered Bartonella quintana infection, and 11% correctly answered epidemic typhus. Next slide. Moving now to fleas. On average, participants correctly answered about 5 out of 9 flea knowledge questions, and the composite score was slightly higher in outreach compared to shelter settings. Next slide. Looking at some of the individual components of the knowledge score now, we see that the percent of participants who selected the correct image of flea bites, which are shown on someone's ankle in this photo here, was 70%. Bed bug bites were the second most common image selected. Next slide. Nearly all participants were aware that fleas live on cats and dogs. Next slide. Slightly fewer participants knew that fleas live on mice and rats. Next slide. And even fewer knew that fleas live outside in wooded areas. Next slide. When asked which diseases can be transmitted by fleas, the majority of participants again responded, "I don't know." Among the diseases that were selected, plague, Lyme disease, and cat scratch disease were the most common, cat scratch disease and plague being correct answers. Only 10% correctly answered murine typhus, caused by Rickettsia typhi infection. Next slide. In terms of staff practices, most staff were unaware of how to manage body lice or fleas appropriately. While some participants knew that showers and laundry or flea preventives were important, they also thought that clients and their pets would need to isolate, they would require medical clearance prior to reentry, or they would be removed from the shelter altogether to prevent spread. Next slide. We also found that the barriers to disease prevention were different for people living in encampments or on the streets compared to those living in shelters. Next slide. In shelters, staff cited several barriers, with the key barrier being lack of education and awareness of risk. Next slide. In encampments, staff cited different barriers, including that being in outdoor spaces leads to issues with rodents and stray cats, and there being a general lack of hygiene services. Next slide. When asked which education modality was most preferred by participants for future trainings, the majority selected in-person trainings followed by online modules. Next slide. In summary, workers providing services to people experiencing homelessness have limited awareness of the pathogens that can be transmitted by fleas and body lice, and the reported barriers to implementing prevention and control of the diseases differed across settings. In shelters, lack of education was cited as a key barrier, while in outreach settings, lack of access to hygienic services was the main barrier. Guidance on the appropriate management of people experiencing homelessness who suffer from lice infestation or flea bites is needed. Staff preferred in-person trainings and online modules for future trainings. Now I will turn it over to Anne, who will present the companion animals component of this presentation.
Wonderful. Thank you so much, Shannon. Next slide, please. For many of us, pets play an important role in our lives. The same is true for persons experiencing homelessness. It's estimated that between 5 and 25% of persons experiencing homelessness have pets. We know that there are a number of benefits that pet ownership can provide to everyone, including safety, a sense of responsibility, and improved mental and emotional health for their owners. Next slide, please. However, we also know that pet ownership can come with some challenges, and these may be exacerbated when owners are experiencing homelessness. Research has shown that people experiencing homelessness may prioritize their animals' care over their own well-being. In a study by Ramirez et al., people experiencing homelessness frequently reported that their pets were in better health than they were. Pets can also pose a barrier to seeking shelter, since not all shelters or support services are animal-friendly. Even if shelters do allow pets or other animals, they may not be equipped to actually provide care for these animals. Animals, especially those that do not receive regular veterinary care and that spend more time outside, may pose risks of disease transmission to their owners or to other animals. And we as veterinarians know how important veterinary and preventative care is, and this can be challenging for resource-limited populations. Next slide, please. During this work, we sought to understand the policies and practices around animals in shelters, as well as what sort of care these animals were or were not receiving from these facilities, so that we could help develop appropriate resources for staff. I'll start out with some results from shelters, and then we'll move on to the results from outreach sites. We just mentioned how pet policies in shelters can be a barrier to care. And from our work, we learned that of the 59 shelters where we conducted site assessments and where this data was available, 46 facilities, or 78%, reported that animals were allowed in the shelter. However, at some sites, staff members provided conflicting information. Next slide. We know that access to care can be a challenge for these owners and animals too, and we wanted to understand if shelters were providing any sort of veterinary care or preventative medications. 98% of shelters reported that they did not provide veterinary care, and 15% reported providing flea or tick preventatives. Next slide, please. We also wanted to better understand what standard procedures were used for screening and treating animals in the shelter for ectoparasites. Was there any sort of inspection or assessment when animals were brought into the shelter? 20% of shelter workers reported that animals were screened for fleas or flea bites. We did not assess if these workers could identify flea infestations on animals. Next slide, please. We also wanted to know if flea treatment was performed routinely at the shelters. The majority of participants responded that there were not steps taken to treat fleas at the shelters. A few replied that fleas were treated at admission or at regular intervals. However, we just saw that very few shelters reported providing flea or tick preventatives. Next slide, please. We wanted to understand protocols around managing animals that were found to have fleas or flea bites. And when asked if an animal that was found to have fleas or flea bites was kept away from other animals, more than half of shelter workers replied that these animals were kept individually away from other animals and people. However, knowledge of policies among shelter workers was limited. Next slide, please. Now I'll share some results from some of the outreach sites that we visited. Next slide, please. When we asked the outreach teams how many clients had pets or other animals with them, the majority reported that less than 25% of clients had pets or service animals. Next slide, please. We were also interested in learning how outreach teams approached situations where animals had fleas. This particular question was free response, so we grouped similar responses into buckets that are shown here. Most respondents would refer to a veterinarian, a humane society, or a low-cost clinic. Other common responses were, I don't know, or they would recommend products or treatment. Next slide, please. I wanted to take just a moment and share some of the quotes from outreach team participants when asked, what would you do if an animal has fleas? And some of these responses included, assume the client has fleas, figure out transportation so that the animal can get adopted while the patient is in recovery, talk to the client about how to avoid being bit while the animal has fleas, use diatomaceous earth for the environment that they are staying in, and some respondents noted that there were problems with follow-through even when connected to scheduling a veterinary appointment to receive care. So as we can see, there's significant opportunity for staff education here. Next slide, please. We saw in shelter settings that access to veterinary care was limited, and similarly, 93% of outreach teams reported that they did not provide veterinary care during outreach visits. Next slide, please. And lastly, we asked if flea control services or medications were provided during outreach visits, and 93% reported that flea control medications or services were not provided. Next slide, please. So in summary, we know that service and companion animals play an important role in the lives of people experiencing homelessness, but they do present some challenges. These pets or other animals can be infested with fleas or other ectoparasites and live in close contact with their owners, but access to veterinary care and preventative medications is very limited in both shelter and outreach settings. There's a lack of screening upon entry to facilities, and knowledge about how to treat fleas is low. Supporting the pets of persons experiencing homelessness should be a priority. Increased education related to flea treatment and better access to veterinary care and preventative medications is necessary. This presents an opportunity to increase staff education and to also increase access to veterinary and preventative care for populations that might otherwise have difficulty accessing it. Next slide, please. All right, and now I'll share some larger conclusions from this project. Next slide, please. We saw that staff recognize that body lice and fleas are a problem for persons experiencing homelessness, but they have limited knowledge about the diseases that they can transmit and what protocols they should follow for their management. Additionally, there are misconceptions about how to treat body lice and fleas, which could inappropriately limit access to necessary shelter services and housing. Next slide, please. Prevention of body lice and fleas in these settings should follow a four-pronged approach. To prevent body lice, access to hygienic services, including showers and laundry, is essential. Access to flea preventatives for companion or service animals, as well as pest control and trash removal services to prevent rodent infestations, are crucial components of flea prevention. Individuals and their animals do not need to be isolated or quarantined from shelters or in encampment sites to address these vector-borne diseases. Next slide, please. The results from this study will be used to develop educational training for staff. Our team is actively developing material to increase awareness of flea, lice, and associated diseases and appropriate protocols to follow for their management. This will include a PowerPoint slide deck to share with state and local public health officials for use for on-site trainings, online modules for continuing education credit among clinicians. And lastly, our group is collaborating with the Office of Readiness and Response to create a shelter standards manual for prevention and control of infectious diseases in homeless shelters. This manual will include specific chapters dedicated to vector-borne diseases and ectoparasite prevention. Next slide, please. And with that, I would like to thank our team members as well as our public health partners, without whom this study would not be possible. Thank you.
Thank you so much to all of our presenters today. Next slide. Unfortunately, we don't have time for questions today, but email addresses for today's presenters are included on this slide on the ZOHU call webpage for today's webinar and in today's email newsletter. A video of today's webinar will be posted within 30 days. Please join us for our next ZOHU call on November 1st. Thank you for your participation, and this ends today's webinar.